Thank you so much for the invitation to join me this morning at your symposium. It's very exciting to be here. As you heard from that, I'm a GP over in East Surrey, and I've also got a number of roles across the NHS Surrey Heartlands system. I'm a sort of renegade academic in some ways, in that I was an NIHR academic clinical fellow at the Department of General Practice at the Institute of Public Health at the University of Cambridge between 2008 and 2012. And I was really interested in research in the area of prevention. But I was also working as a GP alongside training as a GP, and I can see that there is a huge gap between the evidence on prevention and then what was actually happening in the real world. And I decided that I would leave my academic career to try and implement what I learned in research. And so what I'm going to talk about today is that journey. But it's really exciting for me, sort of 10, 12 years later, to be looping back into academia. And I was going to do the talk this morning in 3 parts. First of all, talking to you about an initiative called Growing Health Together, which is a large part of my work today. Secondly, talking about the evaluation of Growing Health Together, which has been funded through NHR ARC KSS. And then thirdly, I was going to talk about neighbourhood development in East Surrey. I think because we're starting a little bit later today, I may skip the third part of the talk, if you'll excuse me, but I'll see how we get on with time. So probably none of you in this room have heard of Growing Health Together and you've got no idea what this initiative is. But to introduce you to the idea, I'd like you to hear from some of the community collaborators I work with, so you can hear it from their words.
Wonderful place here, look at it. Look, this is life up here.
Isn't it just?
Fresh air.
It's good to get out together.
It cures a lot of things naturally.
What does Growing Health Together mean to you?
It means having a community space, allowing the community to establish their own groups.
We have a home now. We have a place where when we go to, they would always listen.
Yeah, we've got so many different groups that have come out of it. We've got Sen's group, we've got a women's group, we've got a gardening group, we've got a warm hub coming, Camarado's coming, public living room, we've got all sorts of different groups.
I'm actually out every day of the week now.
It's affected my health and well-being by having laughs with the women, by meeting so many new people. I've met so many different friendship groups now I've got, so it's just been amazing.
What's been different, like since we've been working together, what differences have you noticed?
We can see that the black community in Hull, they're getting out there.
It's actually helped our well-being. It's built up my confidence and make me know that it's possible for us in the community to actually achieve as one.
There's all ages we have. I mean, I think in my hub, I think I'm the eldest one, but I don't care. I class myself as the youngest.
The community is getting tighter and closer.
We're all included in this.
Yeah, it's just community-led, basically.
Exactly.
So that is Growing Health Together in the words of some of our fantastic community leaders that we work with. But hopefully in a minute you'll see a slide which will show a different conceptualisation of the same theme. So our overall ambition for this initiative was really co-created through a number of conversations, starting off with conversations in my consulting room, listening to my patients. And they were telling me things about what was wrong in the local area that they felt had made them fall ill. Or in some cases, I might give lifestyle advice to help them improve their condition before going on to some sort of drug. And they would say, yeah, but I can't do that. I don't know how to cook, or I can't afford healthy food, or I can't exercise because I can't afford the gym. And lots of other things were coming through. And I would hear similar themes over many, many years from many different parts of my population. And eventually I thought, is it really good enough to just be treating these people and then sending them back to the conditions that made them sick, which is something that Sir Michael Marmot, many of you will know of his work, he talks about. And then over coffee one day, I spoke to the senior partner in my practice and asked him if he was hearing the same things from his patients, and he was. And then I kind of challenged him, or we challenged each other, should we try and do something about it? And we ended up having a series of meetings with head teachers in the local area, who were seeing the same issues, with faith leaders who were seeing the same issues, with community groups and community leaders and charities, and they were all seeing the same things as well. And just before the pandemic, we decided, why don't we work together? Why don't we pool our resources and our passion and our love for this community and see what we can do to try and tackle some of these issues that we know are real and live and happening to people at the moment. And from the beginning, it was really heartening that all the people involved in our conversations were all passionate about helping to improve and address health equity. Obviously, in the health system, we talk about this all the time, but it was the head teachers and definitely the community leaders and all the other groups, to be honest. We all wanted to work to try and improve the health of our population, but to invest even more in those who hadn't been served so well by our system in the past. And the other common ambition we all had from the beginning was to work around sustainability, both in terms of the environment. We really recognised that the health of the environment that we were in, or the lack of it, was contributing and impacting on people's health and well-being. And we recognised that the health service is also often negatively impacting on the health of the environment, and we have a responsibility to try and address that. And we can see that health and social care is completely unsustainable. And we felt that if only we could get upstream and try to help people to live healthier lives, that would be a good way to try and support sustainability, both financially and in terms of the workforce in the local health system. I've mentioned already that the work is absolutely informed by research, not only on prevention, but also around the wider determinants of health. And I talked about how the work developed from conversations in my consulting room through to conversations with colleagues. And I set up an action learning set. This is our community of practice. We're over lovely meals and walks in nature and looking under the stars and singing together sometimes. We talked about what should we be doing and what should healthcare look like with all these problems in the world at the moment. And then those are the head teachers. That's one of the community meetings we had. And then during the pandemic, we had started to progress some practical projects in the town of Hawley, which is adjacent to Gatwick Airport, if you've ever flown out of there. And suddenly the system leaders in NHS Surrey Heartlands had heard about our work. And because of the pandemic really putting health inequalities on the map, suddenly what we were doing, which was it was a passion project for me, and I was doing it in my spare time, weekends, evenings, all unpaid, because I loved it and I felt that I wanted to do it. But suddenly they wanted to pay me to do it, and they wanted us to spread it across all the primary care networks of East Surrey to set up and sustain a community of practice and undertake an evaluation. So naturally I jumped at the chance. And luckily, through the community of practice that I'd been running, I had a whole host of GPs who were passionate about this area and wanted to jump on board and work with us. So we appointed our team of Growing Health Together GP leads. And each of these has a half day. To start with, I think it was half day a fortnight, but now it's half a day a week to spend on addressing these and progressing these objectives in the area in which their practice falls. And rather than ask the GPs to deliver a programme that we'd come up with in a boardroom or something, we actually just asked them to connect. And there was a theme coming through earlier about relationships in the introductory speeches, and that was what we felt was important. So to connect with people and places who were creating health and well-being in the primary care network area. And for those of you who aren't familiar with primary care networks, they are kind of different groups of GP practices in a similar geographical area. And then we asked the GPs to be listening to the challenges, a little bit like I set out at the beginning. What are the barriers to people really fulfilling their best lives and flourishing health and well-being in the local area? And we also asked them to listen to what's strong. So what's strong as well as what the challenges are. And then when they identified challenges, rather than asking them to fix it, and as GPs, that's kind of what we've been trained to do, just to fix everyone's problems, as though that were possible. Of course, it's not. But instead, we wanted to flip that round and actually ask impacted communities what their views were on what needed to be done. And then wherever possible, put the power and resources in the hands of impacted communities who best understood what issues they were facing and potentially could see solutions that we might be completely oblivious to. But some of the issues communities were raising were actually things that they could never possibly fix. For instance, a lack of a cycle path. we need our county council to help with us with that kind of issue. So often our work involves connecting communities who've got issues with the relevant people in the system. So I'm going to give you some examples of initiatives that have come up through this way of working. And I must push the video to play again, so you can see these lovely patients of mine doing their exercise. So after the pandemic, or through the pandemic, lots of my older patients were saying, Dr. Orrow, I'm so worried I'm going to fall over and break my hip and running and go into a care home because I've become so frail since the pandemic, being in my house. And I would say, well, we've got volunteer-led health walks. Would you like to do that? And a lot of them would say, I can't go for a walk. I'm not strong enough to go for a walk. So we spoke to the vicar's wife, and she connected us with this wonderful exercise instructor, Annalise. And soon we set up the chair aerobics class. And now, I think 2 or 3 years on, 45 people are going every week. And through tracking the impact on their patient notes, we've seen that their blood pressure is generally going down, their markers of blood sugar are going down, BMI going down, weight going down, consultation rates going down, and lots more. This is another fantastic group that is has been born through my wonderful colleague, Dr. Uzma Aziz in Red Hill. So in Red Hill, we found from population health management data that there were poorer health outcomes in South Asian communities. And Uzma worked with South Asian community leaders to set up the Asian Women's Wellness Hub. And they're doing exercise, they're doing health talks, health walks, cycling, and a lot more. And they were mainly older women, then their daughters wanted to get involved. So now there's a spin-off sister circle with the younger women as well. And we haven't forgotten about children. In the area of Tandridge, which is on the eastern side of East Surrey, we heard from young people that there wasn't enough to do. And there's a mental health crisis in young people that I'm sure you're all familiar with in this room. And through a collaboration with Growing Health Together, the local schools, the leisure centre and others, the Friday Night Project was born. And this offers inflatables, swimming, boxing, dancing, and a lot more activities every Friday for young people. It started in one leisure centre. I think 120 young people turned up in the first week, and it's always been oversubscribed since then. It was so popular, we started another one at South Tandridge, and now it's spread across our patch. And we've also got a Friday Night Project for young people with special educational needs. Then we're really proud to support a number of community-led initiatives. These are just two. Warren Clark Golfing Dreams is led by a family, all of whom are autistic and have learning disabilities. And they offer nature connection and physical activity for people with different disabilities. And we've done outreach health checks with these communities too. Also love to support Africa Community in Surrey and Sussex, who've done so much to support Black communities, particularly in the Hawley area, but across East Surrey. And they do fantastic cultural events, sharing food. Jollof rice is so good. Music, dancing, but also outreach health checks, talks on how to get a job, how to get housing, how to access a GP, and much, much more. And they're now collaborating with the local hospital to improve sickle cell care. There's a great project led by Dr. Tabassum Siddiqui in Merstham, an area particularly affected by health inequalities, to invest in the first 1,000 days, particularly in minoritised ethnic families. And really that is just the tip of the iceberg. There's community gardens, community orchards, there's care farms, intergenerational music and art projects, and a whole lot more. So as you've hopefully heard, there's like a lot of activity just through kind of making the connections, listening to people, and then trying to shift the power and resources so people can do things. But naturally, as we were doing this work, people started to say, oh, what's the evidence? What's the evidence that it's working? And we were absolutely thrilled when we were approached to apply for funding through ARC KSS to evaluate Growing Health Together. And then we were so thrilled that we were successful and that I now get to work with a fantastic research team to do our external evaluation. Now, these slides have kindly been prepared by Dr. Sarah Hotham and Dr. Sharon Manship, who sadly couldn't be with us today, but I'm grateful to them for sharing these slides with me. Here's our wonderful research team. So as well as Sarah and Sharon from the University of Kent, we've got Jenny Monkhouse, who's our patient and public involvement lead. And we're very grateful also to work with Dr. Sam Fraser and Harm van der Marwick from ARC KSS. So we've talked about how there are already an evidence base for what we are doing, both in terms of it being a place-based intervention and also, I think, some of the components of the interventions. So, for instance, a lot of our work is around helping people to be more physically active. And we know from a huge body of research that if we're more active, it improves our health outcomes. Likewise, social connection, likewise, nature connection. So we didn't necessarily need to reimprove the evidence on each of the interventions, but increasingly we're approached regularly by different systems in the country and to some extent internationally of people wanting to take what we're doing and apply it into their own context. And so there was a desire to understand, well, what are the active ingredients and how did you manage to embed the idea in the system and in fact affect that system's change? So this piece of research is very much trying to get into the nub of that. The first phase of the research was mapping both the demographics of our population and also the activities and the personnel, the people involved in leading these activities. And then the second phase was leading on qualitative interviews of those who've been involved or those who are in our system, whether as a professional, patient, or community member. And then that's been supplemented by questionnaires. Now, Sharon has been leading on the interviews and she has been interviewing citizens who've developed a new scheme, citizens who attended a new scheme, GPs who were involved, GPs who were not involved, and then CEOs of the health system and local authority, voluntary sector and so on, and a whole plethora of other partners. And there are about 100 pieces of data that have come in, which is, I think, quite a lot above what her expectations were for this. Now we're in phase 3, which is developing and piloting an active ingredients framework. And this is just a sort of preview, really, because it's still in development and it's very early draft. I'm just going to focus on the areas that are coloured in this chart. So the outcomes that have really come through so far are that at an individual level, this intervention has resulted in improvements in people's physical, mental and social health and well-being, health behaviours, health literacy. And at a community and organisational level, it's resulted in some improvements in social capital, engagement in healthcare. For instance, through the Africa community, we heard that many people were not engaging with healthcare at all. And there were many other groups that we'd encountered where people had no teeth, undiagnosed diabetes, undiagnosed hypertension and so on. And through making the trusted connections with GPs, they were then subsequently able to access healthcare in a way that worked, which they didn't trust before. And then there are several other wider impact ripple effects, which we'll discuss further when we present the findings. In terms of active ingredients, so far, the research suggests that the fact that this is community-driven is important. The buy-in from many different partners in the system was important, both the public and the system partners. That we are focusing on prevention and wider determinants is really key to this piece. We have a distributed leadership approach to the work. So in each of the areas, the GP who leads on this, who knows that area best, absolutely calls the shots. Although I oversee the work, we like it to be distributed and decentralised as much as possible. And then so far, the research has suggested that ethos of our work has centred around emergence, flexibility, inclusion, advocacy, and listening, which I think I would agree with. There is a bigger framework that we need to spend more time unpicking, but throughout it is this golden thread of relationships between people and also the importance of asset-based approach and co-creation. So the next step is really to finesse that model that I just shared and then to share more of our findings in greater depth with others who are interested in these approaches and who might like to adopt them in more areas. I'm sorry that I am not close enough to some of the detail of this to be able to answer any detailed questions on the research side, but Sarah and Sharon are very happy to be contacted and their email addresses are there. 5 minutes? Yeah. Exactly. So this is just to show how the work that I've just described is always quite dynamic and it's always changing. It's not static, that we came up with that model 5 years ago and now we'll keep going with it. Things change. So one of the new developments 2 years ago was the Fuller Stocktake was published by NHS England. Does anybody in this room, people familiar with the Fuller Stocktake? Maybe nobody perhaps, but it's a document about how to future-proof primary care and general practice. And it was written by Professor Claire Fuller, who was CEO of NHS Surrey Heartlands until recently, and is now NHS England lead for primary care. And this was a document advising us to localise care and deliver care closer to people in neighbourhoods, which is fantastic. And around the country, people are all doing this now, which is fab. But because in East Surrey, we had for 2 or 3 years prior to the publication of this document been developing relationships with our communities, we felt that rather than simply implement a kind of top-down vision for this document, designed locally in Surrey, we actually wanted to involve our community members in shaping the vision for this piece of work and what it would look like. So we did exactly that, and we had a number of workshops across East Surrey. I think about 250 people came across the series of events, and we had our system leaders sitting side by side with community members with all sorts of different lived experience. We had babies up to people in their 80s, all sorts of different disabilities and backgrounds. It was absolutely fantastic. And as a consequence of that, our system leaders in East Surrey said that they would commit to, in their transformation work, working at neighbourhood level with communities, listening to them and giving them resource to do this bottom-up health creation work, which was really exciting. And we then decided, because our population asked us, they wanted to be involved in supporting improvements in health and social care on an ongoing basis. So we knew that we needed a forum to be able to come together and enable this. So we established health and wellbeing networks in each of our neighbourhood areas of East Surrey. This is getting a bit technical now, but I talked earlier about primary care networks and how they are groups of GP practices in a similar area, but often they're not grouped in a way that's meaningful to our populations. So our population actually helped to define for us what would be meaningful areas of geography. So we said they're the neighbourhoods, what our patients tell us, and we'll set up a network in each of these areas where people who live or work in the area can come together and tell us what we need to be doing to improve both upstream prevention work, but also actual clinical and social care in our local areas. And they've been meeting quarterly for the last year, and loads of brilliant things have come out of it. So there have been more health creation type groups. For instance, we heard that LGBTQ plus communities were underserved and they wanted more sober spaces to come together. And our local library stepped up and provided a group there, which has been really well received. But there have also now been clinical changes. For instance, a new housing estate was built with 1,500 homes, and the developer had promised there would be a GP surgery, but the health system had never been asked to give that promise, and it wasn't possible to deliver it. And the population were really upset and didn't feel they could get a GP appointment. So we worked with the council and the local developer to get clinical rooms put into the neighbourhood hall, the community hall that was being built. So now we're hopefully going to be doing satellite GP clinics on this housing estate. And that just never, ever would have been possible before we had those relationships in the health system between us, the local authority, and the local population. And there have been loads of other examples. For instance, carers weren't getting the support they needed. Some people were digitally excluded and couldn't book their GP appointment online. And there have been loads of different examples of how we've listened to people and then worked together to overcome the issues that they faced. And now the next iteration of the work is that our social prescribing service was previously a little bit siloed and separate to the work that we were doing in communities and with Growing Health Together. But now we're kind of integrating that and making sure that that's really aligned with people in there who are actually doing fantastic work around social prescribing in their local communities. I think the sweet spot that we're trying to get to, and I think to some extent we've kind of been trying to maintain over the past few years, is this credibility with our community, also credibility within our health system. And I'm not going to talk about risks, but perhaps someone will ask me about that. And I'll stop there.